Welcome to Boombostic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change. Each week, we bring you candid conversations with top experts, innovators, and leaders, exploring the latest trends and technologies shaping the future of healthcare. Join us and be part of the conversation in transforming healthcare. Hey everyone, Bradley Bostic here. Welcome to episode 17 of Boombostic Health. Today we have an awesome inventor, innovator, and leader in the field of blood management, Jason Carney. In full disclosure, Jason also works with me at HC1, where I am CEO. But this is not about our business. This is about the importance of the domain that Jason has really built his career in. And it's something that's really not very well understood. I've heard that the description of blood transfusions as being like a liquid organ transplant. So it's not like it's just another fluid you're infusing into somebody. This is a big, big deal. And as it turns out, if you do this right, you can help patients get better faster. I would also like to just mention some of the accomplishments that Jason has had along the way. That's pretty impressive. Jason was the VP of Clinical Transformation he is the VP of Clinical Transformation at HC1, where we work together. But before that, he was at the American Red Cross Biomedical Headquarters and later became COO at Suncoast Blood Bank in Sarasota, Florida. Now, one thing that was really cool is Jason received an award called the Dorothy M. Hampson Award. And the reason that was so cool is he was part of an initiative to eliminate pathogens from the United States blood system, from the United States blood banking approach. And that's a huge deal when you've got these bloodborne illnesses that can literally kill people that are being transmitted by mosquitoes and other sorts of issues. So thank you for doing that. It certainly makes a big difference for people going into healthcare. And then ultimately, he invented My Blood Health, which is now an HC1 solution. My Blood Health, we're going to talk a lot about these concepts today, but it effectively ensures that blood is being utilized in the most effective manner to make patients healthier and also to make sure that we're efficient in how blood is utilized. So Jason, thanks so much for joining me. It's great to have you on the show.
Thanks for having me, Bradley. Appreciate the opportunity to talk more.
And where are you dialing in from today?
I'm in a little town called St. Mary's, Georgia, just a little one stoplight town on the water here on the Atlantic Ocean, one exit over Jacksonville, Florida.
Awesome. So where all the magic happens, which is pretty cool. It's awesome how we can connect remotely like this, and would love to have you back in the studio. I know you were just in recently. Gosh, you've been in twice now. You're developing some real star credentials. Need to look you up on IMDb. So with that said, hey, why don't you just start off, why did you start in healthcare to begin with? You could have been doing a lot of things with your time. What got you excited about healthcare?
I was born into healthcare. I think my parents owned nursing homes when I was growing up. So it was really in my DNA. I think I grew up on the business side of it a little bit, where I watched them run that business very efficiently, taking care of our elderly patients, which is really important and critical. And then I saw things like blood transfusions happen over time, and that really got me interested in blood banking. And so I started my career at the American Red Cross and worked my way as kind of a senior business analyst, is what they called the role, just assessing how blood centers run their operations. And we were responsible for half of the nation's blood supply. So I got a really great overview on how not only it's a business, it was a business, it was an $8 billion business, but it was also very much touches every patient everywhere in the hospital. So I got a lot of visibility into healthcare, and then I wanted to go run my own blood center. So I did for a while, which was nice. And in that time, I was trained as a transfusion safety officer. So I got some bedside time. And I saw that although blood does save lives, there's no doubt about it. It's a precious commodity. And when it's done responsibly, it's important to extend life and to save lives. It also does harm. Anything that does good can also do harm. And so I looked at the way to best ethically use that practice, and I saw that anemia was the leading cause of transfusion, and it's a modifiable risk factor. So why aren't we taking care of patients? It was just so difficult to do. Multidisciplinary, heavy handoff, just a lot of people involved and a lot of data involved. And it was really difficult to piece those data points together to actively assess patients quickly, efficiently, effectively, and to move them into the care pathways that they needed to get better. So I teamed up with a pathologist friend of mine, Dr. Kathy Fry, and we built My Blood Health. We launched it at Fairview Health System in Minneapolis. We published a paper about it and then commercialized the software, and here we are today.
That's great. So you said you were a are a transfusion safety officer. So is that like you go to a certification for a weekend, or what's that? How do you get that level of credential?
It's a certification through the American Association of Blood and Biologics, but it's also a lot of training boots on the ground. So you spend a lot of time in the lab, in the hospital, looking at transfusion level data. So you want to see the indications for transfusion and make sure they're appropriate, and you follow those guidelines. And then you meet with clinicians and ask them questions about the transfusion events that happen. But you also look at transfusion reactions. So every transfusion is not benign. So when something goes wrong, we need to talk about why it went wrong and if it was indicated or not. And so my job was to provide data to physicians to help benchmark them against their peers, and then to help give them education that will help change that behavior, which is what we call patient blood management now. So really it's the stepping stone for that role.
So in a given health system, is there a giant refrigerator in the basement that's full of blood bags, or how does this, what is the actual reality of how this blood is sourced and how it ends up in the health system, how it ends up getting utilized for a given patient? And then once we talk through that, perhaps you can describe how this approach you've devised makes that better and what the bottom line impact is. Does it save money? Does it save lives? Why should a healthcare executive or healthcare leader care?
I think if you're a healthcare leader, you don't know much about blood. You don't know where it's stored. I think, like you said, they probably think, it gets delivered every day and they just dispense it as it's needed. It's not dispensed through the pharmacy. It's in the laboratory. And typically, so I worked and ran transfusion services for a 700-bed level 2 trauma center. And that level 2 trauma center held inside of their facility 300 units of red cells a day and 20 platelets, along with hundreds of fresh frozen plasma and cryoprecipitate. So as the person who ran the blood center, my job was to go out and manufacture this as a drug. Blood centers are FDA licensed drug manufacturing facilities held under the same FDA regulations as any drug manufacturer. The only difference is they're a nonprofit. And so we could talk about how I'd love that regulation to change so they could actually get some of the benefits of a for-profit institution, but I'll shelve that. So once you've now gone out to the community and you've identified people who are qualified to donate blood, you send out your buses, you get them to come in, you manufacture those products, you ship them and store them and test them. And once they are ready for transfusion, you deliver them to the health system and they're delivered to patients. Now, nobody looks at or did not look at in the past the efficacy of what happens after it leaves the lab. It was really a doctor goes on, it's the only transplant that happens with a keystroke. So they look at a patient, they say, yep, bring me up 2 units of red cells. They bring it up, the transfusion happens. Nobody thinks about why does this patient need the transfusion and could we have avoided that?
So Jason, we're talking about this issue of people ordering up a certain amount of blood, people meaning the physician or their staff. How do they determine how much blood needs to be ordered? And how is it that the lab is in charge of this? How does that make sense?
It really, if you think about it, it doesn't make a lot of sense. But how physicians identify the amount of blood that's transfused is typically based on lab values. So they'll look at the deficit of the hemoglobin and say, hey, if I need to go from a 10 to an 11 or an 11 to a 12, maybe I need 1 unit or maybe I need 2. It depends on if there's active bleeding or not. So there's some patient assessment and there's lab data evaluation that happens. Most physicians have very little training in transfusions. They're not, this is not their main focus, transfusion. It's probably 30 minutes of the lecture that they get in college. And They have their practice book from 1970 with some yellow papers hanging out of it. And so studying up on the new peer-reviewed literature would change a lot of that. But yes, it's really a mixed bag depending on who the physician is. Now, the reason it's dispensed from the lab is because a med tech has to cross-match that unit. It's not like the pharmacy where you're just ordering something. Every single unit that's transfused has to be specifically matched for that patient and then tested to make sure there are no antibodies present that may cause a reaction. And again, that it's the right type for the right patient at the right time, just like pharmacy.
Okay, so once you get a transfusion, what can go wrong?
Yeah, I think the most common is a non-hemolytic transfusion reaction, and think about it like, anaphylaxis. Immediately you would stop the transfusion, you would flush with saline, you'd try to give the patient some Benadryl and try to stop the reaction. So that's the most common reaction. There are other reactions that happen when you give too much blood to a patient. So when you over-transfuse, one's called TACO, which is transfusion-associated circulatory overload, and the other is TRALI, which is transfusion-related acute lung injury. And those are probably the two the worst outcomes that you could imagine in terms of a transfusion.
I got it. So getting more into just the idea of an individual's health journey, and people are born and they start having an experience, and eventually they'll intersect with the healthcare system. And ideally, we're doing things to prevent illness. And ultimately, if somebody has some type of condition, we want to proactively address that so they can get better faster. Specifically within surgery, my understanding is that anemia is a big deal. And I think that's in fact, there's the Anemia Awareness Month just was in February, right?
That's right.
And we connected with some pretty interesting leaders that are, that's their mission. So this whole anemia idea, it's not just something where it's about, just take some vitamins. Like, it can actually create a pretty massive issue. How does this blood type of strategy that's more precise relate to anemia? And then how do we grow from anemia within this concept that you are focused on in order to create even broader impact for the health of these individuals that are going through their health journey?
Yeah, that's a great question. So I think if you think about blood in general, right, it's the delivery system for oxygen through your entire body. It feeds all of your organs. So when you do not have the hemoglobin that's delivering that throughout your system, it's a problem in surgery types, especially for people with other chronic diseases. So anemia, it could be caused from inflammation. So let's say you have chronic kidney disease, or let's say you have congestive heart failure. Anemia is associated with both of those comorbidities. And so I look at anemia as a Trojan horse kind of for other disease states. It's a way that you can identify that early. What we know and what the literature is very clear on is that in surgery or prior to surgery, when you address anemia, you reduce the complications that come with that delivery of oxygen in both the surgical process and in the recovery from surgery, right? I had open heart surgery. I know that when my hemoglobin was less than 10, it was tough to pick up a spoon to eat. My hands would shake. Shaving my face was really a chore in the morning. So correcting that anemia is critical for quality of life. As a matter of fact, anemia by itself as an independent modifiable risk factor is associated. It's a top 5 reason for reduced quality of life. And so it really impacts, it impacts a third of the nation's population. So big problem to solve, but usually under-recognized because we're focused on the bigger chronic disease or the bigger chronic disease that's more recognized out there. And so when we think about why we do this and what we're building, using this data to find anemia helps us find other chronic diseases. So anytime we do a workup on an anemic patient, we can also see if they have chronic kidney disease. We can also see if they have congestive heart failure. And so when we create care plans that bounce just from anemia, we say, well, it's just anemia. It's not just anemia. We're going to treat the anemia, and we're also going to recognize these other chronic diseases because we found this in that data while we were looking for this patient.
I see. So there's a process, as I understand it, then, that has a patient getting tested some number of weeks prior to a surgery. So they get scheduled. and that information is able to be utilized to go get them tested. And then the test says, I'm anemic. Now there's an infusion therapy that solves for this versus having to actually get transfused when you have your procedure. And so that's tying into the electronic health record and driving some type of an action or series of actions. So let's talk about this example with chronic kidney disease.
Sure.
How does that look? And where is it that the patient is in their journey where your invention is identifying, here's somebody we can help who's got CKD or maybe is at risk for that? What is that flow? What's that action look like? And how is this benefiting patients?
So when we're scanning that patient record and we're looking at all of those risk factors for a patient, a GFR is probably one of those top signs because we're looking for inflammation, which causes iron sequestration. So it stops your body from making iron. So now when we find this, we know just by a lab value which stage of chronic kidney disease that patient has. And we know that it's a 3-time multiplier of poorer outcomes when associated with anemia. So in the tool, it honestly, it just highlights in red and says, oh, here's hemoglobin bad, and here's GFR bad. 1 + 1 = 5 bad things. And now let's create a care plan that looks at both of those together. So in the tool, it draws your eyes immediately to the problem so that you don't have to go hunt and say, well, what are the other things that might be causing this that we're looking for? We're taking all those out of range lab values and we're putting them right in the face of a clinician. That's what they need, tools that don't make them dig for data.
I see. So it makes it so that the physician or the clinical specialists are able to more effectively treat patients as well, because it's uncovering where you have a patient who needs some type of special treatment that otherwise isn't getting it.
That's right. Typically under-recognized.
Okay, interesting. So thinking more broadly about clinical excellence, we've talked a lot about the blood need. What about just ensuring that all of the patients in a given healthcare system are getting the best possible diagnostic testing, that you can be more preventative and predictive? That seems like another example where the physician took a class for 6 weeks or some number of weeks that was about lab, and that was 20 years ago, and lab continues to innovate, and it's impossible to keep up with all of this stuff. What's your view on clinically how you start to optimize the way people are tested?
Yeah, I get to hang out with Dr. Andrew Fletcher all the time. So, he'll tell me there's a very short cycle of what you learn as a physician in terms of laboratory testing. And so it takes a boots on the ground kind of the activity of learning as you go. And what people don't recognize is that the overutilization of testing, the underutilization of testing, the tests that are, no longer clinically necessary, they still happen every day. And it clogs up the patient beltway so that instead of us getting to the diagnosis faster or the right diagnosis, it's taking longer. The patient's journey is longer, and it's aggravating not just for the patient, it's aggravating for the clinicians as well that are processing. So when I think about what we build and why we build these tools are supposed to pop up and show the clinicians, this is the right thing to do. I'm following the best clinical practice, and here's the results of that better behavior is I'm reducing time in surgery or time to discharge, better quality of life for patients, better clinical practice for providers as well. So really helping hardwire in good behavior for health systems. But I think the real benefit is that when we collect this mass amount of data, in terms of just for our clinical excellence division, and we're building new tools, we know that if they've gone through our program, we are sitting on a highly curated, very top level quality wise amount of data. And the tools that we build, we know the efficacy will be there. We know the quality of the tools will be there because they'll be driven by great laboratory practice, the right data, and to drive our tools and behaviors.
Right. That makes sense. So here on Boombostic Health, we like to make sure that we're linking an innovation in healthcare to an economic engine, because that's what ultimately makes it a viable change that can penetrate healthcare more broadly. So it sounds like in this case, you're saving a lot of money, saving patients from bad outcomes, ultimately accruing to the benefit of the health system's quality scores. Like what's the there as it relates to the bottom line, the economic impact of this whole clinical excellence area?
So I think I'm going to talk just about what we do right now and then what the final vision looks like, because I think they're connected very broadly, but in a very short time frame, we're about to get there. And so looking at anemia, patient blood management, and test stewardship, the impact on managing those three programs, we already have the published data that shows we've saved health systems $200 million plus, inching closer to $300 million. Real savings. Those are hard dollars. We're not looking at soft costs. So this is really blood acquisition costs and savings from testing and new revenue from IV iron in the outpatient setting when you treat anemia. So big bang for your buck in these cases, especially since we've only been doing this only for 8 years or so. But the new solutions now that we have combine all this and really supercharge your time to value as a health system. Because look, the future really is that 75% of all of the cost in healthcare is in chronic disease. That's $4.1 trillion this year the United States will spend on managing chronic disease. So we have to take a bite of that big apple. And the only way we get there is, yes, we start with anemia because, like I said, it touches all these other chronic diseases. So it's really important to identify that. But the program and the process that we built, we can replicate this now with CKD and CHF so that the next generation of our products, which we will release at some point here in the future, will not just touch the blood side of it. We will go into more diagnostic precision medicine approaches to managing chronic diseases for patients across the entire spectrum of healthcare. So obviously I'm excited about it. But the piece that I think really resonates with healthcare providers and healthcare administrators is that they need to have their clinicians available to take care of patients. They can't be building tools or worrying about pulling data from different areas. So they want tools that help them manage that. And that's our job. We're the experts in this. And so we should be driving that in showing them the value in healthcare too.
Yeah. Well, it sounds incredibly impressive, and it really is. This is one of those areas where it runs through the core of how healthcare is delivered. And by diagnosing more effectively, by more proactively getting patients on the healthiest path without a transfusion, and then only transfusing when necessary at the right levels, this generates a massive economic win, but also, most importantly, it's great for the actual patient, which we all are aiming for. So it's great to have you on, Jason. Really appreciate it. And we'll look forward to continuing the conversation in the future. Thanks again for being here for our 17th episode of Boombostic Health. Look forward to seeing you next week. Have a great day.
Thank you.